So good afternoon and welcome everybody. This is the Enhancing Clinical Practice and Outcomes stream of the SNOMED 2023 Expo. My name is Monica Harry. I lead up the content team at SNOMED International. And I just want to remind you about questions. I'll ask you to save anything question-wise until the end. And I'll remind you to use the microphone at that time if you have questions. And online, you can put your questions in the QA section and I'll be monitoring that for you. So now I'm pleased to introduce Paul Seegers from the PALGA Foundation, who will be presenting implementation of SNOMED and synoptic reporting for pathology in the Netherlands. Thank you.
Well, thank you very much for the invitation. I did last year already a presentation in Lisbon, a little bit more about in depth. So for the implementation part, I will go quickly through it, but it's more as an introduction to the part where we want to do the pilot with the patient-friendly terms, what especially can be used by SNOMED CT. So the outline is that we start on with the implementation of the SNOMED CT coding in the national pathology protocols. We call it the PALGA way. This is the way that we do it. And then briefly go to the study, the pilot study for the patient-friendly terms. Why do we need it? And the development step by step. We are not finished yet. I can tell you that up front. So I will tell you how far we are now with these steps and what then the following steps will be. I must say that the idea for the patient-friendly terms come from Pim. He's here in the audience. He many years ago he already introduced it, and I was really fond of it already. And I thought, okay, PALGA can already help with this. So from there, and that's the reason that I'm standing here, I think. And at last, we will say something about the benefits and obstacles along the way. So probably you have seen this picture a little bit often. It's our roadmap to implementation of the national protocols at PALGA. We have a sort of circle what we do, and what I now want to concentrate on, where you see in the arrows and the functional design, and where we started with SNOMED CT. It's stated here since 2022. Actually, we were a little bit optimistic to start then, but actually we are now starting with this. So what you see here is just a snapshot of our functional design. In the functional design, it's an Excel sheet where we're completely reading out all the questions, all the answers, so the observables and all the values, with all the constraints, notes, calculations, and everything on the right side, what is needed to produce such a protocol in a modeled way. In one of the sheets from this functional design, we have here, you see a part of what we do with the SNOMED codes. So every question gets an observable term, and every answer gets an observable term. And we do that per protocol. So we have a lot of discussions with our terminologist. She writes everything down, does proposals from, okay, we think that this should be the code for the observable, and this should be the code for the answer, where you see a little bit here from the type of tumors. It's in Dutch, but you can see some rows there already in English, of course, because the SNOMED code we use is in English. Also, let's say, for the explanations. So, and after that, then our medical terminologists discuss it also with NICTIS to see if this is feasible or not, or should be post-coordinated, or should we use more fields, etc., or, and I'm a fan of that, create new concepts. And here you see a slide from our designer system. We have just recently got an update from our designer system where we can put in on the left side, you see the modeling, a slight part of the modeling of a national protocol part. And on the right side, you see the block for SNOMED. So we can give here the question for the type of tumor, what you saw in the previous slide in the column of type of tumor. And we say here is a Heskel type of malignant neoplasm. We a little bit different what Scott said before, because he had a discussion with or let's say for colon rectum, because this is a part what we use in the colon biopsy protocol. And the reason is that we keep it a little bit in a hierarchy, because it's we have locations going from appendix to pouch to anus. So depending on the location, you can make this kind of decisions. And below you see that, let's say, the adenocarcinoma and the mucinous carcinoma, where this is filled in as an example. And we do that is at the same place in the protocol, also for maintaining later on. I had an arrow. Yeah, okay. So we have also some problems, because we already started in 2008 with creating the protocols, and what sometimes it's not directly as the templates from the ICCR or from Carcipad, but more how the pathologies work in the Netherlands in the way that they speak or want to, let's say, communicate with the clinicians. So here we have an example from where the arrow is that it's a combined question for type of biopsy and resection. So, and then you're getting a little bit into trouble if you want to do this in a good way for SNOMED. So we have in our system, we have now the possibility here to make more lines. So first, we didn't fill it in here yet, but it is more to show you that we can say, okay, for the type of biopsies, we use the mucosa biopsies 1, 2, 3, 4, so you can fill it in. And for the minimal invasion tumors of resections, then we have, let's say, the 10 transanal and the cervical medical surgical, sorry. We can use that, let's say, in another line. So we will split those questions for the SNOMED, so then it will be in line with the way of coding. And here you see a snapshot of the protocol, what is used, and here is in the middle side, you see the type of tumor and a resection question with all the observables of all the values. And you see there on the right side, you see with the arrows there, is that for the type of biopsy, we have chosen polypectomy, and for the type of tumor, adenocarcinoma, and focus a little bit on the adenocarcinoma, because I will take you a little bit further on that road. So this is what the clinicians see. It's flat text, and on the backside, it is just one big XML blob, and with the arrow there, you see also the adenocarcinoma back in this case as a sort of PT item, a pathology item. So it is in a discrete data field. And further up, you see also there with the circle, we have already in place that it's possible to make the file connection. And here's a part of that file connection. We do that together with Nictis. We use the file R4 for this. And also here you see with the code, the adenocarcinoma. So this is what we do. Just this is for every protocol the same, for every observable the same, for every value be the same. So this is the way that we are going to address it. And that means at the end you have a report, and that report contains, of course, a little bit in a structured way, the type of tumor here, adenocarcinoma, and the conclusion that we generate in our protocols. So when we have this and we send this, let's say, we have that, let's say, at the vendor, at the pathology laboratory, the next step is what we want to do is to see from, okay, can we use it not only for research, for other things that you can use, but one of the things is also very interesting to use it for creating patient-friendly terms, something what Nictis is working about. And why should we need that? Well, first of all, in Europe, more and more the patients get access of their own data. And that's quite nice, and I think that's a good way to do it. And they're getting also more control over their own data. What will we share with people, and what will we won't share with other people? And in the Netherlands, we have more than 1.2 low-lettered people, but I think in every country that will be the case. And when you have a report, not let's say a blood results, you see numbers, etc. It doesn't say much at the time, but when you get a report from a pathologist and you see it in your own personal health environment, you see that it's a carcinoma or cancer in plain text, that has impact on a patient. So, and that I think is very important. If you can then give some direction to the patient, what does it mean for you? Not in cases of therapy, but more explaining, so that the first questions that you have, you can then be addressed for that. So Nictus set up a project, and Paul has said, okay, we want to join in this project, and we want to use our national protocol for colon biopsy, because there's a protocol that is being used for bowel cancer screening program and also for the clinical setting. So it's approximately 150,000 protocols per year scattered, and every laboratory in the Netherlands uses it. It's mandatory to use, and that means that every hospital and a clinician gets this kind of report. So that means also when patient has access to his own data, he will or she will can see this. So that's why we want to cooperate with this. So the pilot exists of a few steps. There are 10 here. We divided a little bit. I must say, if you look at the timeline, we are now at 23 Q4. So we're just not that far yet. It is not that we are in step 4. We are already at step 7, that we will go through that. So, but it is still not finished yet. But it is nice to give you already a heads up on, okay, if you're going to approach this kind of things, where do you, what do you encounter? So the initiatives were the Ministry of Health, Nictus, of course, together with the Patient Federation in the Netherlands, and MedMij is an organization in the Netherlands that provides personal health environments. And below you see like parties of Chipsoft, that is a hospital information system, and Cancer.nl, Kanker.nl, that's also a very important one because they have extensive texts for explaining to patients what, let's say, an adenocarcinoma in some cases mean. And in this situation, there were 2 focus groups, a technical focal group and a functional focal group that discuss all those points. So the pilot itself, it just to see in a small scale concept to create patient-friendly terms and use a description by that. So we focused on, okay, how do we do it? How can we do this in the current situation? What are the limits of the project, of course? And the project serves as a test case for the framework from what's the framework we're going to use, and does it work that way? And involving the personal health environment and care portal in the alignment in phase 1. I think this is very important. We come that in a later stage. And then the collaboration in phase 2, but we're not that far yet. So we defined 200 commonly terms used, established by for patient-friendly terms, and it was divided for acute care and also for the PALGA ref set. They use we have, let's say, a standard ref set for 6,000 concept at this moment. That's a very but we use, let's say, in our old database system. And from that, we use the ones that is also in that national protocol from PALGA. And for the acute care, there were 100 from the concept list that were very standard. So to look at it, for that you can start, of course, with can we make something from that? There is a sort of framework. Okay, what should be the content? What should be the margin of error? You can make a structure of that. Which language level can be used? The content, of course, and at the end a little bit overall the shape. So it's very important that one of the things that you want to have in your pilot is that the translation should be in multiple ways, but it should not, let's say, raise more questions. If you, let's say, make a description that you say, okay, now reading the description, I have actually more questions than I had before. Like for the structure, do we use synonyms? Well, do not. Try to keep it as plain as possible. These are the things that constantly thinking about in those layers of in the categories to make this. And actually, this is already a very interesting discussion. And we see during the process, okay, did we need everything what was mentioned here? So what you see here, you don't have to read it directly. You see it in a later stage in handout of. But we got those 200, or let's say for me, 100 concept for PALGA. And a part was done by GDPA and a part was done by a medical translation organization. So we want to see also if it could be used by ChatGPT. We were asked to look at the terms. Are you agree with the term, let's say the patient-friendly term as created? And are you agree or disagree, or do you see that there are minor changes, let's say in the description? We didn't know which one was created by the agency or with GDPA. So we got blind. And I must say halfway, it took a lot of time, 2.5 days, because I thought, okay, we can run through it very quickly, but that was not the idea, because it is just to the letter that you have to see. And then I saw sometimes, okay, wait a second, I see in this case of adenocarcinoma, I see it coming back and back and back. So what I did, I just, actually that was not the idea, but I gathered everything together, and then you saw the differences, but still not knowing what was fabricated by what. So, and from my perspective, from pathology, I say, okay, when you have a code, and you saw a few slides earlier, you see a report. So in the report, you say adenocarcinoma, but you see also other items, and all those other items will be addressed. So you always have not only one answer, but you have to see things in context. So that means in your description, I think, in my opinion, you should say, okay, but the patient see a whole report. So he needs or she needs to know how to interpret the whole report. So try to be objective and not to make it too specific. And this is a discussion what you have to do with each other. Because here you see adenocarcinoma as a morphological abnormality, but you can also see it as a disorder. Okay, what you're going to use? Are you going to say, from our output from the national protocol will be the morphological disorder, not the morphological abnormality, not the disorder. So that means that, in my opinion, for both, it should be the same description and the same type of patient-friendly term. So when you say adenocarcinoma, you say, okay, it's a form of cancer, because the explanation comes after that. If you say it's an adenocarcinoma of the colon, if you want to specify it, we don't use that. But then you say, okay, it's a certain type of the bowel cancer. So try to keep it as, in my opinion, to as highest level as possible. So just we did that for a lot. And then when we made it, let's say, our changes, we asked, okay, we see the descriptions, of course, from IE are adequate or minimal. This is done by NICTIS. NICTIS has reviewed, let's say, what we have changed to see what was there possible from, okay, what was done by IE, what was done by the Medical Translation Agency. Well, and you see that the differences there here is only 90, but that is actually my own fault, because I gathered everything and say, okay, this is the one, this is for the rest the same, because it should be the same. If it's a disorder, if it's a morphologic abnormality, it doesn't care. So, and I didn't know what was. So that's why you see here the difference, but you will see later on that it will be changed. So the medical terminologist also did from NICTIS to see what was in the descriptions. It's very important. And you see, sometimes it's too detailed. And I think that's also very important to know. If it's too much too detailed, that means that it could probably raise more questions for the patient, or maybe not. So this is the things that you have to address. But it is seen by the eyes of the medical terminologists. So there are more, let's say, who are sufficient or correct. Well, there's also a limit. It's sufficient. That means there's slight changes. And you can say, okay, maybe this is okay or not. Well, and next was, okay, one of the points that we say is to be one level. That is what we want to try to get. Well, this is then the translation agency was looking at that. And they say, okay, it's no specific translation to the medical translation organization, OAI. They also have seen it blind, like we did, and they say, okay, the conclusion is it's no B1, but it meets just small changes to meet that criteria. So I think that is actually a good way, but keep this also in mind later on in the conclusion. So it was also asked the rating from the patients. And Nictus has a pool of 2,300 patients. And they said, okay, can you rank the descriptions, so the patient-friendly terms on itself, in the scale from 1 to 4. So you see for our medical translation agency, for the acute care and for PALGA, it's actually quite high. So that means that they actually know and understand the descriptions as they are as the terms. Sorry, that was, just go back. This was for the descriptions that made, sorry. And so you see there is no difference that much between the PALGA descriptions from AE made and changed and the medical agency. So from the acute care, I know that is not my figures, but you see that's also very close. And if we here look at the patient-friendly terms, that is the other way around. And you see for the acute care, it's 72%. And from the medical agency, it's 86%. And for PALGA, it's a little bit slightly higher for the medical translations agency. So I think that the way to give it as a high level of, let's say, a form of cancer or type of cancer is very important to see, and I think that they understand because the description comes afterward. What also is interesting to see, because we said we do it for low-lettered people, but I always say that all people are very high educated, but not in this field, and they have the same problem. If you then go Google or something like that, you still don't know what it means. So actually, we looked at that group of patients, and we see that the mixed assessment for IE and for the transitions agent, there's not that much difference between the primary education or university. So that means everybody scored equal of actual equal. And that means that you're actually on the right way. And that is what you see here also in the general conclusions that we have now made in step 8, when we do the analysis. You see at the 4th bullet, I think that is the most important one, that even that the description were not established to the framework that was previously set, the most patients already broadly assessed the description, said, no, I understand what it means. So I think that you already reach a great goal. From the patient perspective, it is the same to say that the terms and descriptions are easy to understand. It's actually the same, of course. And there is little distinguishing between the description of JET-TTP and a medical translation agency. Interesting, the medical technologists were surprised by the quality of JET-TTP. I like that. But there was also there were some few examples that were shown to us that that was completely missed. So JetTP doesn't know always the context. So you need, and this is one of the things very important to look at that always. It is necessary to review that what you see in the general, in the second bullet. From the medical specialist view, in general, okay, medical translations are more likely to deliver correct translation. I think that I agree with that absolutely. And from PALGA perspective, I think the very important thing is that the description should always be replaced by the context. You can't leave the context out because the patient will see a complete report and will look to everything. So this is, I think, very important. Well, and it's not translated here, but the ancient organization said it doesn't meet B1, but minor changes, and it will be in that level. But on the other hand, it was already understandable by the patients. So based on these results, it's doing the next steps to work out the different scenarios. Is it possible to use AI for translation and then also ask the collaboration with the Medical Transport Agency? I think that working together would be the best to start with, and investigate how the patient will be helped in the best way. And together we'll look at further parties to see how we can collaborate because the landscape for the patients, what you see with MedMate, so at the end where the patient get their patient healthcare or place environment that is not, that's a little bit scattered in the Netherlands. So what are actually the benefits and obstacles from PALGA? We need to fill all the national protocols with SNOMED CT code. So at this moment, there will be more than 20,000 observable to fill and more than 600,000 values initially to start. And so it will be a long-term project. And we are now exploring how to process that and the way to maintain, because that will be very important. And together with MICTIS and the International Cancer Group, we will create a lot of new concepts, especially on the non-core elements outside the templates of the ICCR, ACPAT, etc. So it's very important. And we will look at the expensive, of course, but in the long run, it should save money. And it's also a very good showcase to show what you can do with SNOMED CT, because I think that is in many countries a problem that not everybody see the benefit because it's far behind the clinical daily care. So what's in it for me? That's the problem. So why should I work with it? And clinicians and pathologists don't see the backside, luckily, because it doesn't work. So you have to show good cases to say, look, it's maybe not benefit for you, but it's benefit for your patient. So you then don't get many questions up front before you talk about further patient management. And of course, the landscape in the Netherlands is fragmented in that case, because a lot of companies are jumping in and say, okay, I can create also a personal health environment, or the hospital say it's my hospital where you can log in, but you want to have everything there.
Sorry.
So this is the last slide. I want to acknowledge, of course, the people from MICTIS, especially Lana, Esther, Natasha, Rafaela, because they are pulling this project. We are just doing our part, but that is more small. But they are really pulling this off, and it is really good that we pull this off together. So,
thank you, Paul. Thank you.